Hmm. Okay.
Hey, Mitra, can you hear me?
Hey, Caitlin, I can hear you just fine. Can you hear me okay?
Yeah, I can. Is there any weird echo?
No, it's coming through really clearly.
Perfect. I have two screens in front of me, and I wanted to make sure we weren't picking up double audio before we started.
Oh, okay. No, it's all good. Thank you.
Great. Thank you.
Hey everyone, we'll be getting started shortly. All right, everyone, we will go ahead and get started now. Thank you so much for joining us today. I hope everyone had a great holiday season and is ready for the new year. So I was going to see, Caitlin, would you and Mary, would you guys like to go ahead and get started with the didactic first?
We definitely, I think we can do the didactic first. Do we do introductions real quick?
Sure, absolutely. Okay, so would you like to introduce yourself? It says iPad BB.
Yes. Hey, good morning, everyone. Happy New Year. This is Brian Brown. I'm a vendor who comes to WVU, and I work for an organization that has a lot of interest in heart failure. And I know Mary and Caitlin and Dr. Sokos. Thank you.
Thank you. Okay. And Nell Stewart, would you like to introduce yourself?
Who was that?
Would you like to go ahead and introduce yourself?
Yes, this is Nell Stewart, and I can hear you guys fine, but you're not. Sometimes you disappear for a minute or two, like it's slow streaming or something. I don't know what to do about that, but I work for Marshall University now. I'm a certified diabetes educator.
Hi. Okay. Thank you
And
so much.
that's it.
All right. Great. Thank you. And Corey, would you like to introduce yourself?
Sure. Hi, I'm Corey Grogg. I am a APRN. I do women's health nurse practitioner, and I'm finishing up my family nurse practitioner. I'm practicing in Glenville with many Hamilton Health Systems.
Perfect. Thank you so much. And Charles?
All right. Hi, yeah, my name is Charles. I'm one of the physicians from palliative care. I'll be joining the HVI for palliative outpatient for heart failure patients there. That's about it, really.
Thank you so much. And let's see, Alexandra? I believe it's Alexandra Shaver. She's an RN nurse navigator for population health here. If there's any issue with audio or camera, go ahead and feel free to chat me on the side as well. And Elizabeth? Oh, so she chatted me, or I guess to everyone. So Elizabeth is an FNP at WVU Garrett Medical Group in Oakland, Maryland. Thank you and welcome. And Amanda? All right, I can chat her on the side as well. And we have 3 numbers here. There's one starting with 681342.
Hi, my name is Tracy Brotowski. I am a social worker with Population Health, WVU Medicine.
Thank you so much, Tracy. And a 304845 number.
Hi, I'm Julie Richardson. I'm a disease management coordinator with Population Health with WVU Medicine.
Thank you so much. And the last one is a 502338 number.
Hey, Caitlin. I think it's Caitlin. This is Gipper Munson, and I've been working with the ECHO team around this project. Thanks so much.
Thank you. Okay, and Caitlin, would you like to go around in your group and introduce yourselves?
Yeah, totally. Thank you. So I'm Caitlin Ettinger, everybody. I think you know me. And we're just going to zoom out the camera for a second. And then Mary.
Hi, my name is Mary Cole. I'm a nurse practitioner with the Advanced Heart Failure Group here at Ruby.
I'm Charlie. I'm the pilot grant coordinator for the CTSI.
Okay, thanks, guys. And last but certainly not least, everyone in this room, would you like to start, Jen?
Hi, I'm Jen Lucas. I'm one of the PBRN coordinators here at CTSI.
Hi, I'm Tracy Sun. I'm the other practice-based research network coordinator.
Thank you. And I'm Mitra Motasham. I'm the other Project ECHO coordinator with Caitlin. And
I'm Shannon Molnar. I'm a pharmacist at Allied Health Solutions Specialty Pharmacy.
All right, thank you guys. So this was a great turnout, but we can go ahead and get started with the didactic if Mary is ready.
All right. Give us 1 second. We'll share it and then get started.
Thank you.
Okay, so this is going to be a very basic overview of starting off with thinking about heart failure 101, hopefully laying some groundwork for the rest of the year with both heart failure and general cardiology issues and questions.
I'll let you go.
So how does the AHA define heart failure? They say it's a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to fill or eject blood. So we'll go through some of the epidemiology, the types of heart failure, and some brief pathophysiology, etiology, and risk factors, and then what to look for in your clinic patients who do not yet have a diagnosis of heart failure. So the US estimates are about 5.8 to 6 million persons have heart failure currently, with over 500,000 new diagnoses yearly. This accounts for approximately 1 to 2% of the population in both the US and Europe. Over the past several years to a decade, there's been a trend toward a higher incidence in those greater than 65. And this can also play a role in the increasing prevalence, along with an overall aging population, as well as improvements in treatment for acute heart failure. The Framingham Heart Study did a comparison looking at 3 decades, and they found that the incidence of heart failure with preserved ejection fraction was increased. Heart failure with reduced ejection fraction was decreased, and heart failure with mid-range ejection fraction, or an EF of 40 to 50%, as they defined it, remained the same. And then a pooled cohort study looked at risk of diagnosis of heart failure at 45 years through 75 or 95. And it was highest in white men, 30 to 42%, and Black women, 24 to 46%. All of these estimates are limited by the sources of data they use, claims data and discharge data can be not as reliable, but smaller cohorts don't capture a large population. So thinking about the impact of heart failure, certainly mortality is the first thing. Again, coming back to the Framingham heart study, mortality after heart failure diagnosis is about 10% at 30 days, 20 to 30% at 1 year, and roughly 50% at 5 years. And they did 5 years of follow-up. Overall, there have been trends towards improvement, and this is seen in data in the US, Canada, as well as Europe. But overall, these outcomes still are fairly poor. And like most of the country, heart disease is the #1 cause of death in West Virginia. And nearly 5,000 people in West Virginia died of heart disease in 2017. This was the most recent data available from the American Heart Association. This is a nice kind of visual this comes from the Centers for Disease Control. And this looks at the heart failure death rate per 100,000 across all ages, races, and genders from 2014 to 2016. Again, this is the most recent that they had available on their Atlas website. And the darker colors show a higher death rate. And so certainly West Virginia is in kind of a dark clump there in the middle. And they come in about 113 heart failure deaths per 100,000 over that time frame. Thinking about morbidity, hospitalizations are the most frequently used proxy to think about morbidity and heart failure. The AHA estimates there are over 1 million heart failure hospitalizations annually. And if you account for both primary and secondary diagnosis, that number goes up to over 3 million. There are approximately, there's a 25% 30-day readmission rate after heart failure hospitalization, 35 of which are for heart failure. And that number goes to about 50% at 6 months. So hospitalizations are used as a quality indicator that impact reimbursement, particularly with CMS. But hospitalization is also an independent predictor of mortality, independent of the severity of the disease. So here's another map. This is again from the CDC. This looks at hospitalization rates, and this is in Medicare beneficiaries who are 65 plus, all races, all genders. So I'm admittedly new to West Virginia, so I cannot account for the differences in the southern portion and the western portion, but maybe I can travel to some of our spoke sites and see what's happening with your patients there. But generally speaking, there's a fairly clear definition where the eastern half of the state and the southwestern have some disparities. So thinking about what is heart failure and how do we define it, two general ways to approach it are diastolic heart failure or heart failure with preserved ejection fraction. This means that the squeeze on the left side is preserved, but the heart has a difficult time filling and relaxing. The reasons for this and the treatment for this is really pretty poorly understood. And our goals of therapy are to target all of the other reasons and conditions we can. So lowering heart rate, controlling blood pressure, fluid management with diuretics, and thinking about other exacerbating things like sleep apnea, as well as obesity and losing weight. Systolic heart function on the right side happens when the left ventricle becomes weakened and is not pumping as efficiently. And eventually over time it dilates and becomes enlarged. The goal of therapy here, which we can target and actually have proven therapies for, is to reduce some of the negative neurohormonal cascades that happen, as well as to do fluid management, reduce or address any actual underlying causes that are reversible, as well as to treat, likewise with diastolic heart failure, any conditions that will exacerbate it, helping patients lose weight or treating sleep apnea. So diastolic heart failure or preserved ejection fraction, these patients generally have a ejection fraction of 50 or 55 or above, and that cutoff depends on the society or body that you're looking at. So this is a little bit of the pathophysiology, and this is more targeted towards systolic heart failure. But if you're coming down from the top, you have some sort of damage, insult, and there are structural changes to the heart that happen. And when the output from the left ventricle is reduced and there's lack of arterial filling, it activates the Renin-Angiotensin-Aldosterone System, the RAS system, that's here on the right side. An activation of that system can initially be beneficial, but then becomes detrimental in heart failure. So it causes vasoconstriction, it causes retention of sodium in water, and it can also, over time, lead to fibrosis. On the other side, the left-hand side actually looks at some of the beneficial changes that the heart triggers. And so natriuretic peptides are kind of a counter-regulatory response to the RAS system. These are produced by the body when the cardiac myocytes or cells are stretched out from volume overload. And they have the beneficial effects of vasodilation. They lower blood pressure and sympathetic tone. And they promote natriuresis and diuresis. And there are medications now that target this beneficial side to keep those peptides circulating. Neprilysin, you'll see there, is an enzyme that actually degrades those, and there are medications now to help prevent that breakdown. But on the bottom here, the whole neurohormonal balance is one of the most important things we think about when targeting therapies and when we think about what's actually driving not only the symptoms, but the long-term effects structurally. So etiologies or causes of heart failure can be pretty varied. It can be anything from the first thing you think of as coronary artery disease and ischemic heart disease, viral infections, alcohol or drug abuse, valvular heart disease, hypertension, postpartum or peripartum cardiomyopathies, tachyarrhythmias, genetic causes, as well as idiopathic heart failure that we don't have an answer for. When you think about population-based risk factors, so these are the things that your public health programs, that primary care is really going to target to help prevent heart failure: coronary artery disease, lipids, diabetes. Looking at patients who have had prior MI with particular close attention, body mass index and obesity, and hypertension and smoking. So when you have a patient who presents with various complaints, or you're just doing their annual exam and looking for changes, I kind of broke it out between, what to talk about and then what to look for to suspect that some of these things or symptoms they might be experiencing can be heart failure. So family history is certainly a huge clue to be on the lookout for signs or symptoms. For patients with family history of dilated cardiomyopathy, that can go out to 3 generations. Also, asking patients if they're feeling short of breath or more fatigued, what triggers that, how long that's been going on can give you a little bit of a clue. Or if they have any other comorbidities that could be causing these. And if you think that's well controlled, well, what might be next? Thinking about what their exercise capacity is and how they've been able to maintain their normal activities. This is particularly important with patients who are short of breath. And if it's from a primary pulmonary problem they may have, or if you just think they're deconditioned, it's something always to keep in the back of your mind. Early satiety and nausea. A lot of these patients will also have diabetes, and that might lead you to think, hey, this might be diabetic gastroparesis. And it truly might be, but it is worth thinking about what are some of the other causes of that, or truly getting a full exam, a full workup for what you think the problem is. Palpitations can be ventricular, they can be PVCs, they can be runs of ventricular tachycardia, or it can be undiagnosed atrial fibrillation. Any lower extremity edema or ascites, orthopnea, and then just general medication adherence. So if there's someone who's on antihypertensives, are they taking them? Is their blood pressure well controlled? And then as far as physical exam, you're looking at BMI, their vital signs, orthostasis in particular, looking for heart rate, particularly elevated heart rates, jugular venous distension. This may or may not be part of what your normal exam is, but extended neck veins are a sign of fluid overload or right heart failure. If you hear an extra heart sound, so an S3, or if you hear a new murmur, displaced point of maximal impulse, and then any respiratory changes in respiratory effort, crackles in the base of the lungs, or elevated respiratory rate, hepatomegaly or ascites, and then again, peripheral edema, and then temperature of the lower extremities. This is a little bit less sensitive in primary care and other areas, but perfusion to your lower extremities is an important thing when you're looking for decompensated heart failure, and is just another point of the physical exam. So when we think about stages, it seems like the majority of folks on this presentation will probably be seeing people with stage A or B heart failure. So A is truly just high risk. You have all or some of those high risk features, but you don't have any structural changes or symptoms yet. And stage B is where you do have some sort of change, but you have not yet developed any symptoms. So no vital signs changes, no symptoms of shortness of breath or fluid retention. And then stage C and stage D. Stage C is you both have changes and you've now become symptomatic from your heart failure. And stage D is end stage heart failure, where you're symptomatic at rest, just despite maximal therapy or needing to lower what your previous therapy has been due to vital signs. So this was just kind of the 101 kind of warm up for a lot of things that are on the agenda this year. So we'll also talk about diagnostics, medication management, and advanced therapies. Thank you. Are there any questions? We can do those or go right to the case.
Thank you. No, that was wonderful.
Thank you for that. Again, if anyone's audio is having some difficulty, feel free to chat us on the side with any questions or comments you may have. All right, well, if anyone does have questions or comments you think of later on, feel free to email me as well, and I can pass them along to Mary. So I guess we are ready for the case presentation, if you all are ready on your end as well.
Yeah, actually, we have two new people here. I'll just let them introduce themselves real quick. Over here.
Hi, my name is Rachel. I'm one of the pharmacists that works up here with the heart failure team.
Perfect. And then.
Hello, Dr. Sokas, one of the heart failure cardiologists here at Ruby.
Great, thank you guys for joining us. And Dr. Sokos, if you would like, I could pull up the case anytime that you are ready as well.
Sure, sure.
Okay.
Okay, so I just put together a simple case just to show that we don't need extreme amount of details when we want to talk about cases here on a weekly basis. And Dr. Cackmo just walked in the room here too. You're on camera. Okay. One of our other heart failure cardiologists here. I just wanted to show something like, this case is pretty, I think pretty common. It's something you'll see in the office, but I just wanted you all to understand that if there's something, you don't need to have every detail of a case to bring it up when we talk about things. It's just something to bring up so that we can discuss something you'd be doing every day, some simple tips that you may want to, understand the things that we do quickly, or any just kind of simple question. Something you said about maybe you figure something out on a patient, but you may try to figure out what happens. You could figure something out sooner. Doesn't matter. So I just want everybody to feel this form. I filled it out this morning. It took me probably 15 minutes tops. And we really, really, really want cases from everybody throughout the consortium. So please fill them out. Again, simple, and you can even just put basic stuff here and explain the rest when we're talking. I don't care. I just think it's a good idea to have things that we can discuss. Right, Caitlin?
Yeah, absolutely.
Yeah. Okay. So get rid of that default.
I don't know. Hey, Mitra, do you care to exit out of that little box at the bottom?
Oh, is it the control right there?
It's the default box. Yep, there you go. Perfect.
Great, thank you.
Go through the case.
Okay, so this particular case, we have a 55-year-old gentleman who, white male, classic patient that we typically have here in West Virginia, if you think about that. It's the majority of our patient population. He works as a mechanic, is married, smokes, doesn't drink, smokes some occasional marijuana. What he says is for his back pain, but nothing, no other illicit drugs. He says he has a history of hypertension and high cholesterol. Sees his primary care physician for it, but a couple weeks ago was having some cough and some mild shortness of breath. A lot of people in his family were sick with bronchitis, and said couldn't get into the office, so went to the urgent care. He went to the urgent care. He said he probably had bronchitis. Gave him a Z-Pack. Continued to be short of breath. Didn't really feel like he had much of an appetite. Was tired all the time. Felt some occasional palpitations, but this is not all that uncommon for him. Had some a little bit of lower extremity edema, but says, my legs swell at the end of the day anyway, and so didn't think anything of that. And he now comes to the office saying, I didn't get any better from the urgent care, still not feeling right, and can you help me out? So I think that's pretty classic patient that you all see in the office every day, I would imagine. And I don't think necessarily heart failure is going to be at the top of your list when you see this kind of presentation. I mean, I can tell you that we see a lot of patients that come to us that get treated for bronchitis or some other upper respiratory tract infection because it can be confusing as an initial response, initial symptoms, heart failure, and can mimic this. So I bring it up to that just to say that I bring this cape up to say, keep that in mind, that this is something that can actually happen, and you're going to see it. You probably are seeing it. You may not think about heart failure necessarily up front, because a lot of people, he's an obese guy. I think we have his stuff down below as far as his weight. He's 235. So he's 6 foot, 235. And he has a lot of he can have some edema at the end of the day. I mean, it's not, he's up on his feet all day. So he is not thinking twice about that. So you're not necessarily going to go to heart failure, think about heart failure up front, for just someone having some lower extreme edema and what you think is bronchitis. So he but when you see him in the office, he's got a heart rate of 115, and it's irregular. So we got an EKG, and he's got new onset atrial fibrillation. We got some labs that really are non-revealing as far as his chemistries, and he has a chest X-ray that someone's reading as maybe left lower lobe infiltrate, and it's got a right pleural effusion. So, I look at that and I think, why does a healthy 50-some-year-old have a right pleural effusion? I can understand he may have a pneumonia. He's a smoker, and we're thinking maybe he has a pneumonia with this possible left lobe infiltrate. But he also has a right pleural effusion. He's got some edema. He also has some elevated jugular veins, so he's got jugular venous distension, and he's pretty hypertensive with a blood pressure of 145/90. Not very hypertensive, but still hypertensive at 145/90. So when you look at this, you got someone who has new onset atrial fibrillation. They have some lower extremity edema. He's got a right pleural effusion suggesting that he may have some maybe heart failure, maybe volume overload. We don't know. But I don't think this is someone you're going to put on another round of antibiotics and send home, right? This guy's got new onset AFib, and we don't know that he has heart failure. We just know that he has some little bit of extra volume. We know that he has new onset AFib, and he's not hypotensive. So I think you could go a couple different ways on someone like this. You could say, okay, I'm going to put him on something to some anticoagulation, try to slow his heart rate down, and see if that makes him better. But I think you'd want to think twice about that, because if someone is experiencing some symptoms that you may or may not think is heart failure and they're tachycardic, that's not someone you necessarily want to slow down. Now, this guy's in AFib, so it may be that he went in AFib and has been tachycardic for a while and didn't realize it, and that's causing him to be in heart failure. But I think, we don't know anything. We don't even know he's in heart failure right now. We don't have an echocardiogram. We don't have anything. So I think this is a good place to pause and say, okay, what kind of testing would I do next? So I would kind of open that up to all of you all, because I'm sure you see something like this all the time in your office, or even in the ER or wherever you guys practice. Anybody have thoughts?
Hi, it's Charles from Palliative here. Dr. Sokas, you just mentioned something really interesting to me. I just wanted to hear your thoughts and the current thinking. You mentioned that we don't have an echo yet. I remember way back when, and I had this discussion with the cardiac fellow, and I was like, his clinical situation, the patient that I had, typical fluid overload, shortness of breath, and all that stuff. And I was like, his clinical situation sounds like cardiac failure. And he mentioned to me about BNP and echo. And I was under the impression that cardiac, heart failure, is more for clinical diagnosis. So do we really need all this investigations to be like, all right, this is heart failure? I just wondered what the current thinking is on that. Well,
you have to try to figure out is, okay, if you're making a clinical diagnosis, as a gentleman saying that I think he's volume overloaded, the BNP that was elevated, you still don't know why. You don't know if he has preserved ejection fraction, because the treatment is totally different of what you would do. Mm-hmm. If this gentleman has an ejection fraction of 55%, then you can make an argument that, okay, he's an AFib and he's got, long-standing hypertension. Maybe he has some diastolic heart failure. He has, significantly stiff left ventricle. you're going to slow him down, treat his blood pressure, maybe try to get him back into sinus rhythm. We have no idea in this scenario what's happening. So you need test to help guide you in which direction you're going to go to, because you don't know what you're going to do from a medication standpoint. Am I going to use evidence-based therapies for reduced ejection fraction? Because let's think about it. If this guy has a reduced ejection fraction, you have to rule out ischemia as a cause of reduced ejection fraction at some point, and not just think that it's going to be, a new onset AFib, versus the echo looks relatively normal otherwise, and he's short of breath. He could be short of breath just from having atrial fibrillation, and maybe he does just have some lower extremity edema from being up on his feet and some venous insufficiency. So you have to have all those tests to help you understand the etiology and to help you understand what other tests you need next, because it's going to lead you down multiple different pathways.
Right. No, I full on agree, but I guess my question was, do we need tests before we say heart failure? Because tests, yes, it's gonna determine your treatment, like you said. But in my mind, if I'm like, all right, this guy's got heart failure, he's got heart failure. I just need to know what kind, right? So that's where my confusion was, really, to be quite honest.
No, I think you need to know. I don't think you can. I mean, if you think he's volume overloaded, to give him diuretic may not be wrong.
Mm-hmm.
I mean, are you gonna? I mean, let's give you a good example. If you're gonna slow him down,
right?
You don't know what you're gonna do. Are you gonna give him? Are you gonna? Is he? Are you gonna slow him down? Is that gonna hurt him? Is that gonna help him? You don't know, because it could be tachycardic for multiple reasons. You have to know on structurally. Is it valvular heart disease? I don't know. That's a totally different treatment. Yeah, it could have severe MR for some unknown reason. He could have something that you're missing on exam. You have to delineate all those little small details in order to know which what kind of different. Because are you going to hospitalize him or you're not going to hospitalize him?
No. All right, thank you.
You know that just based on the on a HPI.
All right.
Next.
Thanks.
I don't know, Dr. Giacomo, your thoughts?
No, yeah, I think, you think he's volume overload, but it doesn't necessarily mean that he's truly in heart failure. I think if you didn't have the lab work, for example, if his creatinine was 8, he could have edema, he could have pleural effusion. I mean, I think it's trivial of, I think the big thing is, an echocardiogram and workup and so forth. You can definitely say volume overloaded, but I try not to always just say heart failure right off the bat, because sometimes there's causes for the volume overload, like Dr. Sokos mentioned. The classic in the inpatient side is someone missed a few rounds of dialysis and then they say that he's in heart failure. Well, no, it's that they missed a dialysis session. So I definitely think volume would be one thing and heart failure can be a different. Just because he's short of breath, could be the AFib. Like you said, heart failure is a clinical diagnosis, but I think it's really hard sometimes to tell right off the bat what's going on until you kind of get the.
I'll give you another example. So let's say breath, he has edema, you think it's heart failure, and maybe it's just right side heart failure, and then you get an echo and it looks like he has severe pulmonary hypertension from some other reason. Different than putting him on some sort of medication for heart failure, you're gonna treat someone for pulmonary hypertension. So you don't really know, right? And we don't know much about. He's a smoker. We don't know nothing about his lung disease too. So a lot of times that someone could be volume overloaded and appear to be short of breath and volume overloaded. So that's the reason I say that, because I think you want to have all the information possible so you can make the best treatment decisions. In the 15-minute office visit, I think you're going to understand. I agree with you. You're making a clinical diagnosis that he's volume overloaded. You're going to give him something to try to take some volume off, but I think you have to understand a little bit more of the details to exactly where you're going next. You know a general direction you're going, but how heavy you want to get into all that is that's just my thoughts.
Thank you so much, Dr. Sokos. That was wonderful. If anyone else has any comments or questions, please feel free to ask them.
So when you were talking about the cases, you mean you want like the outlying clinics to submit like patients that we have?
Yeah, I mean, that's
okay.
I think that'd be, for me, that's extremely, I don't know, someone that you're like saying, I'm not sure what I want to do with, or an interesting case that you think other people may benefit from that maybe you thought it was something else, try to be we would like to the subject matter of the day. But it's just
Right. So I'm in Glenville, and so it's patients don't always necessarily can't or won't travel very far. So the option of submitting a case to get your opinion or anybody's opinion is a good thing.
Yeah, I mean, I think that's one of the benefits of having this. I mean, it's not going to be, without seeing someone, you're not going to get all of the information, but enough to be able to help a little bit, hopefully.
Sure. Thanks.
Hey, so, I see myself now. So to all of the people on the call, I know we've seen several of you in different sessions, and we love seeing the newer people on the call. If you have any questions about case submission, Mitra and I are more than happy to help with that. And honestly, we would love to just take any cases we can get so we could talk about it and really talk through cardiac health and heart failure since it's so new.
Thank you, Caitlin. Yeah, absolutely. We're always here if you have any, hesitation because you're unsure how to submit a case. We can walk you through it and, go through it step by step with you. So, did anyone have any other questions or comments? You can chat us as well, and I can read them out loud if you would like.
This is Bob Gorowski. Can you guys hear me?
Yes, thank you.
Okay, I'm having a little internet connection problem. Sorry about that. But a case like this, it might be interesting to talk about how different people would approach it as a group. A guy like this, I would probably start diagnosis, workup, and treatment in my office, and wouldn't necessarily send to cardiology right away. What do the cardiologists think about that? Are they still there? I didn't know whether they left or not.
I'm still here, Bob. I'm still here, buddy.
Okay.
So I think everybody has a different comfort level, right? And especially everybody also has different resources around them as well. If you have the ability to run most of those tests either in your office or nearby, I think it's perfectly appropriate. I mean, but if you're not comfortable with what you want to order or where you want to go next, I think it's also appropriate to send it to someone like a cardiologist. But my feeling is, again, I think it's good to start to work up, get some good information, because then you really should what to do next, right? That's my
yeah. Well, in my practice, a guy like this, an echo is like part of the vital signs. Yeah, I might have an idea that it's not a bronchitis anymore, and we've got to look at fluid overload and the whole heart failure spectrum. So I'd be starting this guy on a little Lasix, maybe a little beta blocker to slow him down at first, and getting the echo as soon as I can, and then go from there to stratify what the further treatment ought to be.
Right. I think one thing I would say it's important is what I wouldn't do in this scenario is I wouldn't start a calcium blocker, right? If you have no idea what his ejection fraction is, and start a calcium blocker in someone who already could have a reduced EF, it's not something you want to do because they're negative. It's definitely a negative inotropic agent. Beta blocker.
Yeah.
But I think this is important of knowing what to do is what not to do. And in this scenario, I definitely would not put them on Partism or anything like that.
Yeah, it makes sense. I have one of those butterfly echoes in my office, so I would take a look at a guy like this right in the when I saw him back and have an idea whether his EF is 20 or 30 or or normal, and that helps you a lot.
Absolutely, we use it on almost every one of our patients.
Yeah.
For those of you who don't know, the butterfly echocardiogram, it's a probe, an echocardiogram probe that it's not just an echo probe, it's an ultrasound probe that you can use for multiple modalities, and it plugs right into an iPhone. and you can, or an iPad, and you can see instant images in the office, whether that's echo, whether that's a vascular study or whatever. You can't necessarily get reimbursed for that, but it's it's very helpful in diagnosis, get an idea of things. So we use time to look at not just how we function, but we'll look at the inferior vena cava and try to look to see how much volume overload someone is. There's lots of things you can do with that.
That's all I had to say.
Okay. Anybody else?
Just me again, sorry. So if you guys do have any questions or topics you want to talk about, this is our first session. It's very early in the new year. We have plenty of time to plan for things and time to work them into presentations if there are specific questions that the hub can address.
Thank you, Caitlin. So we have about 15 minutes left. If anyone had any other comments or questions, we just have a few announcements as well before we part ways. So our next session will be on January 17th, and Jennifer Thomas Chrissy will be presenting the didactic on steps, tests, and labs to diagnose cardiac illness. And as Caitlin mentioned, please feel free to email us with any topics you'd like to hear or any questions. If they do relate to today's session, we will address them and we'll reach out to Mary. Thank you, Mary, for the great didactic as well, and Dr. Sokos for the case presentation. And I also said in the chat, we do have our direct links to the case submissions and our recap emails, which will be sent out later today after today's session is finished. So keep an eye out for that, and feel free to email us with anything that you'd like to have addressed. But if anyone else has anything else they'd like to say before we end the meeting, please feel free.
Well, I only want to say I've already told George this, but I'm happy with your slight change in the program to make it one that appeals more to primary care and not so esoteric. I think this might turn out to be a little more valuable for the audience. I hope so.
Absolutely. Thank you for that feedback. We're really thrilled with the turnout for today's session. Like Caitlin said, it's our first one for the new year and the very first cardiac health for primary care. So we're really excited and happy that you all joined us. All right, well, if anyone has anything else, feel free to email us and we'll get back to you as soon as possible. Thank you guys for joining us.
Thank you.
Everybody.
Thank you.